As you know, my name's Wendy Hartridge and I run the CIS programme in the hospital. I'll talk a little bit more during the presentation about that, but thank you very much for inviting me to come today. I'm going to talk about hot debriefs, where they fit in the system and how to do one. Okay, so hopefully we'll cover in the next hour what the theory of debriefing is, what and how to hot debrief, and hopefully for people to feel reasonably confident in delivering a hot debrief. I'm hoping that everybody who's on the chat today will be able to deliver one. And what happens after a hot debrief? Where does it sit in the process? So thank you to everybody who put something in the chat about what is a debrief. So the themes seem to be about learning, support, feedback, reflection, and how we can do those sort of activities. Now that's actually quite a lot to do. And I guess if you're coming to a group debrief and you're expecting to learn something about what went well and what didn't, and actually the debrief is all about support, we can get into a bit of a muddle. So I guess that highlights some of the difficulties with using the word debrief, because it means different things to different people. And when we go to a debrief, we may go expecting something very different from what happens. So as a psychologist, if I was offering a psychological debrief, there may not be any learning in that debrief at all. It might all be focused around support. So anybody who would be going for that and actually not wanting to talk about how they feel about the event, that might be very, very difficult to manage. So I guess that's just a little bit of a plea about the use of the word debrief. We need to be really clear what it is that we're doing. So as part of the CIS service, we try to step away from that debrief word, because actually I think in terms of the medical debriefs where there's a lot of learning about what happened, that's absolutely appropriate. And I'll talk about the differences between the two on the next slide. So yeah, it's just a bit of a kind of be careful about the word debrief. We need to be really clear what it is and identify that prior to the session happening, about what it is that we're expecting to happen. So debriefing, the actual purpose of debriefing, has a bit of a checkered history, a checkered evidence base. So we know that a clinical debrief or a medical debrief, which is about reflection and about learning, there's lots of good evidence that they're a really worthwhile activity, that people get a lot from them because they're kind of based on understanding what happened, the facts of the event, and then how we move on from that and how that affects the next time we come across that particular incident. Psychological debriefs, on the other hand, have a much more questionable evidence base. There's lots of evidence that suggests they're not very helpful and can actually increase psychological distress. And there's some evidence that some types of psychological debrief are helpful. Now that comes from the way that the data was collected, and actually the studies have not been very robust. So it's still an area for lots of work around actually what a psychological debrief contains and whether they're helpful. In terms of it being a psychological debrief, they're led by psychologists and they do focus on the aftermath and the impact, so how people feel about what happened. So why do we do debriefs? Well, there's a sense that we know that getting together after an event that happens is really helpful, that we need to be sharing what happened, we need to be learning from it, and we need to feel supported and comforted by our colleagues. So what we do know from the literature is that key elements in spontaneous recovery for people who've been through a traumatic event are feeling supported by the organisation in which it happened, talking with friends and family, good coping skills, a low number of additional life stresses on a personal level, and relatively good mental health on a personal level. So there are some organisational factors in there that are really important following a traumatic event that all sorts of debriefing show evidence, good evidence for, and some that are personal to us. So I'm going to talk about the importance of hot debriefing, which is not a psychological debriefing, nor is it a clinical debriefing. It's something that happens in that immediate moment after an event. It dovetails with what we do in the SIS project. It kind of starts that process off and leads into the next stage. So a hot debrief is something that's done in the moment. It isn't an isolated incident or event. It's part of a debrief pathway, and that's what we're starting to develop in our work at NUH. So the hot debrief is something that happens immediately after, but there's something in my last talk that I came in and did with you in July, we talked about preventative work. So there's a preventative element to debriefing, making sure that the department has a culture where we look after each other and support each other and connect with each other. Then there may be an event and there's a hot debrief. And then what happens next in the pathway, we'll talk a little bit more in detail about that, but actually how are people going to be supported as an ongoing process? So a hot debrief, because it happens immediately after the event, people are usually not, they haven't processed what's happened. They're not in the place where they're going to be making meaning or understanding. It's a bit like I came in at the end of the previous speaker. It's a bit like we don't know at this stage what's happened. We haven't kind of thought it through, or where we are in the process, or whether it's going to lead to harm. So that idea that actually in that moment we're still figuring out what happened, and we're still figuring out how we feel about it. So it's peer support in the moment, and it's about connecting with colleagues and making sure that everything is kind of followed up beyond that point, so that we're checking in with everybody just in that moment. It's not about learning, because we haven't got to the point of meaning making about it. When and how should we do a hot debrief? So they're not routine. They are only to be done in response to a particular event. They're immediate. So there's some data around about when's the optimal time to do a hot debrief. I would say probably same shift, largely because we know that more than 48 hours afterwards, it becomes people have already started to make meaning and to kind of cognitively assess what happened and put an interpretation on it, and that changes it into a psychological debrief post kind of 48 hours. But I think logistically, if you think about where teams are, if we don't catch people on the same shift, they dissipate across the hospital and we've lost them anyway. So I would say immediately same shift. If you can do it immediately, particularly for those colleagues who, for example, visit ED or other departments, once the event has ended, often you'll go back to your own department, back to theatres or whatever. And it's difficult for anybody to capture what happened. The idea of a hot debrief is not a psychological debrief. You don't need a mental health professional to do it. It's not a medical debrief, so it doesn't need to be anybody with any particular medical ideas about what's happened, or an idea of the whole plan. It just needs to be somebody senior, I think. So it can be either a senior nurse or a doctor who's been involved in the incident. Anyone can lead. We assign that in the moment. So if it's been a particularly distressing event and the members of staff who have been involved feel unable to lead because they are too involved in what's happened, it can be any senior member of staff, which we've trained the duty matrons to do this hot debrief. So anybody like that can lead this. It's only a communication tool. And I'm going to describe exactly how it works. And the leader works through the stages on the sheet, and it's based on psychological first aid, which we again is part of our debrief pathway, if you like, at NUH. So we teach psychological first aid as part of the staff wellbeing offer, and we also will come and teach it in departments if you'd like to have a presentation about psychological first aid. We find it's really helpful. I'll talk a little bit through that. It's a really helpful tool to help us think about what people need immediately after an incident. So our hot debrief is based on psychological first aid. What's really important in terms of the next stage, what happens after the hot debrief, and whether we want to refer into the CIS pathway and TRIM, is that names are collected. So you'll be aware that at the weekend, it was a very, very difficult time in particularly in PZD. We had some difficult shifts over the weekend, and actually collating the information about who was there, because we didn't have a register of who was there because there hadn't been a hot debrief, the opportunity for a hot debrief. That took one person almost 2 full days to follow up and make sure that we found out who was involved. And we don't want to put that kind of burden on people. So having a list of names collected at the time is really helpful. It also gives people the opportunity to discuss whether referral onto the CIS inbox would be appropriate and whether people would like their name to go forward. Again, giving permission to be put forward is a really important part of the process. So it's great that it's a proactive event, but there are some members of staff who really do not want to be contacted, and we need to respect that. And that staff are not mandated to attend either process, neither a hot debrief nor a cold debrief or a trim chat or whatever it is that we go on to refer into. Staff do not have to attend that at all. It has no impact on their working life, and they can choose. So by psychological first aid, so there's lots of evidence that psychological first aid is really helpful following an adverse event. We know that people are much more likely to cope and recover if, again, it's back to this theme of feeling safe, connected to others, hopeful about the future, and that they have access to the support that they need. So that's social, physical, emotional, practical support. And that people have some agency in what they can do. So feel able to help both themselves as individuals, but their communities. So we know that the evidence from the World Health Organization suggests that that's really important. And part of psychological first aid is asking that question, what do you need from me? So this is the model of psychological first aid that we use at NUH. It's used throughout the NHS. It was developed for us during COVID based on a number of different models of psychological first aid. There are 7 core helping actions in there. The first being that we care for any immediate needs. So if you can imagine somebody's been physically hurt, a member of staff's been assaulted, we need to make sure that they're physically okay first. So once we check that people are physically okay and that they are out of danger, we protect them from further harm. So that's that second action, is protecting from risk, from further risk. So we might take somebody or have our little hot debrief out of the area. So for example, sometimes it's okay to do it in the bay or next to the bay where the patient has been, or if in the theatre if the patient has moved on. But for example, if we're in ED in resource, actually it might be better to move out of the resource bay and into a side room. What we want to do is protect people from further risk in our first instance. And then next we want to comfort and console people. So if anybody is distressed, we want to make sure that they are feeling slightly calmer over the next few moments. So we might want to do some breathing with them, do some grounding with them. So if a member of staff is particularly distressed, we can do the hand grounding technique. So name 5 things you can see, 4 things you can touch, 3 things you can hear, 2 things you can smell, 1 thing you can taste. So we're grounding somebody in their body, because the distress comes from the interpretation, what's going on in our heads. It's all about the thoughts. So what we want to do is ground people in their bodies so that they're in the moment with us, they're in this present moment with us. So we want to comfort. We might give somebody a hug or just a kind of touch on the shoulder or something if we feel that we know them very well, but making sure that people are calm enough to partake of what's happening in our hot debrief. The next part of psychological first aid is to support people. So is there anything that you need from me right in this point in time? So again, if somebody's taken for example, something's happened and somebody needs to contact family, or they need to do something, or in order to clean up, they need to contact the childcare provider or something. Can I help with that? Is there anything that you need me to do? What's useful to know, I'll talk a little bit about this towards the end of the presentation. What's useful to know if you're going to offer a hot debrief is knowing what's out there. So knowing what NUH does to support people, but also what the normal response is to a distressing event. So just have that level of knowledge that you can offer to people to provide information on coping skills, on what's available and the support around them. One of the main purposes of a hot debrief is that connection and the contact with our support network. And one of our big support networks is the team that we work in. So a hot debrief connects us with that network. And we want to encourage people to use that, to use us for support, and also to tap into their normal social support, friends, family. So you'll see how that works as part of the hot debrief. And a little bit of education about normal responses to traumatic events. So again, just that little bit of preparation. If you're going to run a hot debrief, just knowing a little bit, reading around, or perhaps just having a little bit of knowledge or thinking through what you could offer to people, or having that information to hand. And right in the centre of that circle is making sure that we take good care of ourselves. So actually running a hot debrief, they're fairly straightforward, but actually in terms of looking after other people, it can be quite emotionally draining. So again, in preparation for that, I would request that people have a good think about where your support networks are. And actually, if you have had to do a hot debrief, where are you going to go for support afterwards? Do you have a person that you can just give a quick call to and say, oh, I've just had a really hairy moment and, you know, I've had to do a hot debrief. Is it okay? Have a chat with you. So when would we do a hot debrief? I guess that's up to you. It very much depends on the area that you work in the hospital and what sort of things come through. But these are the sort of things that we've collated over the months that seem to cause the most levels of distress. So maternal or child death always causes huge levels of distress for staff. Unexpected death or cardiac arrest. Drug errors can be a real heart stop moment. Again, just thinking about your last speaker, that kind of idea of, oh my goodness, I've done something that might result in harm. So those are also moments we can think about for the team to pull together and support each other. Moments of incivility, so particularly if we're dealing with a difficult case and we've got a bit kind of shirty, we can address that in a hot debrief. And if requested by staff, and you might have other potential opportunities to run a hot debrief in your area, but those are some of the major ones that we want to think about. Okay, so what is a hot debrief? So it's as simple as this process. So I've based this very, very closely on the TIM model of debrief. All of the hot debrief models are pretty much the same. They follow exactly the same structure. What I like about the TIM model, which comes from the Intensive Care Society, is it is literally, you read it from the card. So if you have a look at the Intensive Care Society, have a little video that you can watch about the TIM model. And again, I'd like us to have a consistent model of debriefing across the trust. So if we're all doing the same model, that kind of makes sense to me, because we all know what we're talking about. So how they implement them in critical care units across the country who are using the TIM model is they do some key trolley training across the department, so everybody knows how to do this. And this is a laminated sheet. So exactly what's on the screen in front of you is a laminated sheet, and it There's one on the wall in every bay, by the doors. So anywhere that potentially you might need to do a hot debrief, which is anywhere, there's a laminated sheet on the wall, and whoever runs that hot debrief takes the laminated sheet off the wall and reads from the card. So everybody knows how to do it, everybody knows what's on the card, and it's really straightforward. What we're also doing at NUH is we are, over the next couple of days, we're going to produce a QR code, which I will send around to everybody who's on the call today, so that you can hold it on your phone. So anywhere in the hospital that you are, if you want to do a hot debrief, it's there, it's at your fingertips. So you can just kind of download the QR code, it'll link into our staff wellbeing pages on the intranet. And as long as you're in the hospital, you'll be able to access that. So there's two sides. This is side one of the card. And it's as simple as this. There's a preparation part, so we stop. So that links into the, if you've seen stop 5, stop. And you pull the team together, whoever was involved. It's not compulsory if somebody says, no, I need to step away, I don't want to be part of this, that's absolutely fine. But if we can, just assemble the team, pull them to one side, to a side room. Just being mindful to the location. So yeah, perhaps slightly away from a resus bay or something, but actually if it feels okay to be where you are, that's fine. We don't want to be interrupted, we don't want to be in a busy corridor, so just step in to somewhere that feels a little bit safer, but not too far away, because you want to be able to be done quickly and easily. We're aiming for 3 to 5 minutes, no longer, because we are just using this as a communication tool and a start of that debriefing process. And you choose a leader. So your preparation is fairly simple. We stop. Where are we going to stand and hold this? And you can do it standing up. We don't have to be sitting down or anything. We just kind of do it standing up. And then the leader reads from the card. So they thank everybody for being there and for the job that they've just done. And then whoever, probably the most senior, but it doesn't really have to be the most senior person, but somebody who has an overview of what happened. 1 to 3 sentences, we ask them to tell us in 1 to 3 sentences what happened, just the facts. So we might say that person might say, patient X was brought into the department by ambulance and we attempted resuscitation and it was not successful. It's as simple as that. It really doesn't need to be any more complex than that. We're not trying to, as I said, this hot debrief is not about learning lessons. We're not at that point yet. It's just about the facts. The next thing we do is ask, how is everyone? And people, again, it's not compulsory to answer. So people might nod, shake their heads. Somebody might volunteer how they're feeling. That's okay. And then we say, it's okay if you're not okay. It's absolutely normal to feel shaken. And then we flip over onto the other side of the card. And again, we just read from the card. As you get more familiar with doing these, you'll find your own way and your own methodology, your own language for it. But actually what we want to do is make this a really simple, straightforward activity that starts that debriefing process, that connects everybody, that feels supportive. And this is the best way to do that. So we read across the top and it says, it's common to feel shaken up. You may find yourself feeling a bit more on edge, not sleeping as well, more emotional. And you can add other information in there. For those who are trim practitioners and who have lots of information about that, you can talk a little bit about some of the impacts that people might feel. This is completely normal. There's no link between our reactions to an event and our mental toughness or ability to do our job. How you're feeling is a normal reaction to an abnormal event and can last up to 6 weeks after the event. And then we ask the question, is there anything anyone needs just now? And there's a little, you probably can't see because it's very tiny, but a little reference back to that psychological first aid, just as a kind of a point of reference for anybody who's running a hot debrief about what you might be thinking about in that moment. So it might sound a bit clunky, it might sound a bit pre-rehearsed. That's okay. What we want is just to kind of have that communication tool so that people have the opportunity to say if they need anything. Then what we might do is either, if there's a number of cards available, we can read through the useful actions together, or you can, again, just read them out. So what we want to remind people is don't go home immediately. So we know from evidence-based that if we send people home in the middle of a shift because they're distressed because something's happened, we isolate them from their network of support. So actually the support that we're able to give them at work, we remove them from that, which can have implications for problems further down the line. So what we want to do is encourage somebody to stay if they possibly can. If they absolutely can't stay at work, then that's something that we can't kind of affect. But actually, if we can persuade them just if they need a cup of tea or something, if they'll come back to the area and we can have a chat with them. So don't go home immediately. Don't avoid. So often people will get signed off sick. And again, that can become avoidance of thinking or being back at work and thinking about the event, which again we know is not that helpful. We need to be able to manage that and think about things at an appropriate level. Talk to someone you trust. Treat yourself as you would your best friend. So again, I always talk about psychological first aid as being, what would you do if your best friend turned up on your front door one evening in tears? What are the things that you would do for your best friend? You'd invite them in. You'd ask them if they wanted a cup of tea. Do they need anything? And you'd listen. And that's essentially what we're doing with psychological first aid. So we need to remind people, treat yourself as you would your best friend. We say, do something positive for yourself when you go home. Put the event to bed before you go to bed. So do something that is either distracting or that we write down the event, or do something that puts it to bed so that we can sleep. We put essential tasks on hold, get plenty of sleep, avoid alcohol, take some exercise and get some fresh air. All things that have good evidence base in terms of helping with spontaneous recovery. And we ask people to try and stick to their normal routine. So again, coming into work, making sure that they go to bed at a reasonable time, that they eat when they're supposed to eat. So all of those things are really important in terms of spontaneous recovery. And then we say, if you need additional support because your day-to-day functioning is being affected, talk to someone. So what we're looking at here is the traumatic stress response, which is absolutely normal. Everybody will respond in a particular way to an event. That's absolutely normal. It's a normal response to an abnormal event. But what we say is, what differentiates traumatic stress from PTSD is the impact on our day-to-day functioning. It isn't the emotional impact, it's the impact on day-to-day functioning that makes the change in terms of diagnostic categories. So we say to people, if your day-to-day functioning is being affected, please talk to somebody. And then just, again, reading from the card, we want to think about the wider team. So consider who could be affected, cast your net wide, who might be on the periphery that we don't know about. So for those who use TRIM, you'll be aware that TRIM is a proactive, all-encompassing support function. And what we look for in TRIM is those people on the periphery who may not be in the immediate sites. And despite our best efforts, they do get lost. So the cleaners, the porters, the bystanders, people who have seen what's gone on, who aren't in your immediate huddle. So keeping an eye out for those people over the next few days or in that shift. Look out for yourself and look out for each other. And then we go back to the first side and we ask permission to write a full list of attendees. I would encourage people to at least write their names. And if they don't want to be, if we decide that we're going to follow up and they don't want to be followed up, they can indicate that on the attendance list. Keep this list in a safe place. I tend to recommend emailing it to yourself, and then you can destroy the piece of paper, or if you're keeping it on your phone, that you put it in your one of your inboxes. And then as a group, decide if you want to refer to CIS. We'll talk a little bit about that to remind you what the process is. And then if you've agreed that it is going to be a CIS or a TRIM event, that you email that list to the CIS inbox. So you could do that straight away from your phone. If you've got the kind of QR code, once you've done the hot debrief. And again, something that crops up in other types of debrief, it isn't in the TIM model, but I've added it because I think it's really important. It's just to sort of remind people, is there any restocking of equipment that needs to happen? Any notes or immediate learning that needs to be taken forward? You don't discuss this, but actually you can make a note of that to bring to any medical debrief that subsequently happens. And I would thank everybody again for being there and for being at the hot debrief. So again, if you're going to download the QR code, it will have that as a third page. And that's all we need from a debrief pathway perspective. If you're going to refer into CIS, name, best contact details. So again, agency staff are really difficult to contact after the event. People who don't access their emails, it's really difficult to have their NUH email. So whatever their preferred method of contact is, and then a brief synopsis of what happened, the time, date, and who you are, so that we can get in touch with you. Little reminder about the CIS service. So that's the Workforce Trauma Support, and CIS stands for Significant Incident Support Service. So we have two methods of delivery. There is SISM, which is, I guess, your psychological debrief, a group psychological debrief that is provided by the psychologists and the chaplains in the trust, and TRIM, which is currently being piloted in a few areas in the trust. And TRIM comes from the military. They're very similar processes, but we obviously looking at capacity and the area of the hospital. When the referral comes through to CIS, we pick the most appropriate one. So in terms of our debrief pathway, this is what it looks like. So there's an incident that occurs, and what we want to see is that the same shift, there's either a psychological first aid or a hot debrief, or a combination of the two, that's delivered from either the on-site manager, a senior clinician, somebody on-site in that shift. It's not something that you have to wait for a psychologist to have done, or anybody else. You can do that from this hot debrief crib sheet. And then within 24 hours, if you've decided that it needs further support down the line, a referral to the CIS inbox. We man that because, again, it's not a, you've done your hot debrief. This is not a crisis service, so the CIS inbox is manned 9 to 5, Monday to Friday. We will pick it up on a next working day. We'll triage the event, decide which way it's going to go, get in touch with whoever referred, and then we start that process. So whether it's a SISM group or a TRIM chat, and that process lasts 4 to 6 weeks. So we do the initial contact within 7 days if we can, or as soon as possible after the event. And then it concludes after 4 to 6 weeks, because we know that most people spontaneously recover in a 4 to 6 week period. And for those who haven't, that's the point at which we need to be picking them up for more professional support. So going back to, if you're going to run a hot debrief, what do you need to know about what's available in the trust? There's actually quite a lot. This is a very brief kind of snapshot of what we have available. Within the staff wellbeing team, we have the CIS service, information about psychological first aid and training around that. We have preventative work, mindfulness that we can refer people into, lots of healthy lifestyle stuff. We know that actually having a healthy lifestyle, eating well, sleeping well, exercising regularly, all improve psychological health. So it's not just about, you know, the kind of traditional counselling or psychological route. We believe that you know, what we do physically has a huge impact as well. Within occupational health, of course, we have the triage, counselling, signposting. Chaplaincy will always support the informal and immediate. Our EAP, Employee Assistance Programme, has counselling support, legal support and financial support. So actually what might come out of a some psychological first aid or a hot debrief is that somebody might require something additional. They might be worried about cost of living crisis, and actually this is just an additional stress in their lives. So we can signpost them to something that would help with that. And then, of course, there's the ICS, what used to be the clinical commissioning group, have counselling and mindfulness and staff wellbeing available through them. There's a little bit on the bottom of the slide. There's also lots of additional support within the trust. There's clinical psychology, organisational development, mentors, mediators, coaches, wellbeing champions, our SOS champions in governance team. So there's lots of opportunities to get support across the trust. So thinking about this debrief pathway, how do we develop that kind of supportive culture? So again, I talked a little bit about this in terms of being prepared for events. I see this as part of your hot debrief or any kind of debrief, is how prepared are we? So I like this idea, and I don't know how much it happens in your department, is that we huddle in the shift. So it's really good. It's helpful to plan in the day, but also to start those conversations about how is everybody. So I've just popped on the slide there. You probably can't read it, but you can download it from the ICS website. It's a nice little crib sheet on how to huddle. And there's literally 4 things in terms of the start of the huddle. So briefly, how is everybody doing today? Is there any learning or something positive from a previous shift that we can use today? How can we make today's shift an okay shift for everyone? And if you need help today, how will you let me know? So again, as we start the day, looking after each other and maintain that throughout the shift, it makes things like hot debrief, peer support, really easy to do because we have that kind of culture from the beginning of the shift. Checking in with each other as we go through, we know where there are difficult cases or difficult situations that we're working with. So again, checking in with each other. Hot debriefing if necessary. So if there is an event, do take time. That 3 to 5 minutes of a hot debrief makes all the difference because it opens up those lines of communication. It promotes psychological safety. It promotes support, and it promotes connection from the organisation and within the team. And there's been a couple of papers published in the BMJ about how well communication is improved in teams that do use huddles and hot debriefs. Make it routine to access and offer post-incident support. That was a really difficult situation. Is there anything I can do to help? Make it okay. So it's not something that people have to be asking for, that they have to be distressed to access, that it's just part of our culture here. And then check in and check out is really important. So if we're going to huddle in the shift, checking out at the end of the shift. So again, there's some suggestions on that crib sheet of checking out, but we also have a going home healthy checklist you've probably seen during COVID-19, which is exactly the same thing. So just briefly, how has today been for everybody? Are there any specific things we need to learn from today or think about differently? Is there anything that particularly troubled you? Take a moment to consider what's gone well. And if I don't see you before you leave, thank you for today. And once you leave, do the best you can to switch off, rest and recharge. So again, we're putting work to bed, if you like, a bit like the kind of making sure that we have good rest time, and we reinforce that during the huddle, the hot debrief. So that you might have seen the going home checklist. That's what it looks like if you've seen it on doors and walls during COVID. Again, it's the same message, making sure that we work out what was good about the shift, if there's anything that we need to learn or do differently next time, and putting the shift to rest. Sometimes you can do something symbolic, such as taking the scrubs off, or taking your ID off, or switching on the ignition of the car, or putting a particular piece of music on. Lots of people have their own rituals about how to end the shift, put the shift to bed, and get on with the rest of our lives. So again, We have lots of information on the staff wellbeing website, including information about CIS, but also things about, that impact staff and ways to get support. So that's somewhere you can go for more information if you're going to hold a hot debrief. If somebody's in crisis, their GP, mental health crisis line, Samaritans, if somebody's really particularly distressed, because people worry about, if I ask somebody if they're okay, what if they say they're not? And that worries a lot of people. Actually, there's lots of help out there. And if you're really struggling, if somebody's really, really distressed, there are places that we can go, and always our own accident emergency if somebody is really seriously concerned about somebody's safety. Again, part of the development of a debrief pathway is the development of our preparation of looking after ourselves. We need to think carefully about how we're going to support ourselves to do this. We're not immune to the distress, and the more of other people's distress that we take on, the more likely we are to feel the impact of that. As psychologists, we have opportunities for supervision, clinical, reflective practice, so that we are offloading some of that somewhere else. Find opportunities to do that, have a peer group, have somebody that you go to, develop it, work it out as a department. What's going to happen if we implement hot debriefs? What does it look like if we're going to do one? How do we get support for each other? I mean, I've worked in the NHS for a long, long time, and middle managers, senior leaders, often are the people who have less access to support, and we need to change that.